Okay, so first of all, I'd like to say that this is Shelley Gladstein of Osteo Boston. I'm founder and the host. And I want to just thank you for getting on if you're part of our group. And please stay on for the second half after our speaker. And I also want to say to our YouTube audience, we really appreciate you. And so thank you for giving us a thumbs up if you like what you heard tonight. And possibly subscribing. It helps us to understand and create better content. So that said, I'd like to introduce, I'm so excited tonight to introduce our speaker. I can't believe that she's here from Australia to speak to Osteo Boston, and I'm pretty thrilled. So Belinda Beck is a professor of, oh, and I want to say one other thing. We met Professor Beck, some of us, in Boston for lunch, and that was really special. You were a big treat for us, and I'm so grateful. I've been reading and hearing about you for a long time, and I couldn't wait to reach out and ask you if you would speak to Osteo Boston. I never dreamed we'd all have an opportunity to have lunch with you. So, wow,
Yeah.
fantastic. Anyway, Professor Beck is a professor of exercise science in the Menzies Health Institute Queensland at Griffith University. She is also the director of the Bone Clinic, a translational research facility and clinical practice providing for patients with osteoporosis. Professor Beck received her BHMS, or Bachelor of Health and Medical Sciences and Education, at the University of Queensland, Australia. And then she went on to receive her master's and her PhD at the University of Oregon. Professor Beck completed a postdoctoral research fellowship in the US at the Stanford University School of Medicine. Professor Beck's work primarily related to the effects of mechanical loading on bone, and it has involved both animal and human models from basic to clinical research. She's presently professor and researcher at Griffith University in Queensland, Australia. Her specialty focuses have been exercising interventions across the lifespan for bone health. In her quest to change the narrative for bone density issues, Professor Beck has in recent years developed the ONERO exercise program for the prevention of osteoporotic fracture and even for helping people to navigate and feel more confident in that area. This program is now delivered all over the world. And so I'm so thrilled to have you here, Professor Beck. Let me bring you up and say welcome. We are thrilled to have you.
I'm delighted to be here. Thanks for inviting me. And I'm pretty impressed, but not believing of everything that you just said about me. But it's a labor of love, and yeah, it's not hard to do stuff when you really love it and you're passionate about it.
Well, we're thrilled. And I thought maybe I could ask you a few questions. Would you like that format? How does that work for you?
Oh,
Or
sure.
would you?
Yeah, absolutely. No problem.
We never talked about that,
Mm.
but that's okay. First of all, I'd love to know, I know you were developer of the Liftmor Study, which we've all read and we're thrilled to we're excited about that. And could you tell us how, that all came to be? And, how did you get there to think of wanting to work on that?
Look, I started my research career in animal research, but I knew that to do that, you have to kill animals all the time. And I decided I didn't want to do that for the rest of my life. So I sort of moved into human trials, which is why I went to Stanford and studied there. And when I did, it became very obvious to me that the biggest problem in the bone world was osteoporosis, and also the biggest challenge was being able to apply what I knew was an effective stimulus for bone, but to actually apply that in humans and have it effective. And it was just a source of mystery to me. So we had done a little bit of work on that. And then fortuitously, we came across a program that seemed like it was effective, but it was also seemed like it would be very dangerous because it was such high intensity. So we thought, well, everybody says you can't do this because it's too dangerous, but nobody has actually ever shown that. So the next step was to recruit a PhD student, put them on this project, and away we went. The rest is history.
Wow. So I know that, one of the things about that is that there's plenty of researchers out there. Maybe nobody was doing something like what you had done. That was like crazy to think about, people that are very compromised in their bones having that kind of load. Because I know that, the Liftmor study involved having people, lift an incredible amount. And then you went from there to develop the ONERO. And, what was that transition like from from your perspective?
It was a natural progression, but that's not to say it wasn't challenging. So, I'm an academic. My day job is, a professor. I work at the university. I teach students and I do research. I'm not a businesswoman. But when we finished the ONERO study, it was very obvious to me that I couldn't just publish the study findings and then just go on to my next project. There was a caveat around it being effective and safe, and that is that it has to be supervised. So that almost certainly is the case in the real world. So I also knew that if I didn't do it, nobody was going to do that. So I just decided to open a research facility. It is a clinic, it's a business, and roll this program out as, available to people. And then everybody who came in would be a research participant. So we do very extensive testing. And then we offer them the exercise program. We called it ONERO. So Liftmor was the name of the research study. So Liftmor is not a thing. That was the research project. ONERO is the thing. ONERO is the exercise program. And it actually comes from the Latin word for overload. That's where that word comes from. It's not an acronym, it's a Latin word. And so then, over the years, we've just been tracking people, and I'll tell you more about that in my talk.
That's great. That's great. So would you say, I know in listening a little bit more about what happened with that, well, should I let you give your talk and then ask you more questions later? How's that sound?
Possibly, because possibly my talk answers some of your questions.
Okay, let me go ahead and let you do that then. Thank you.
All right, so you would like me to share my screen?
Sure.
Just making sure that it is actually.
Yep.
Yep.
That's great.
Okay. So, all right. Well, if you haven't got anything else for me, Shelley, I'll just get straight into it, hey?
Sure.
Okay. I might keep looking to the left because I've got two screens, and some of the images of, the screens of other people are over some of my presenting screens. So I'll be looking at this one over here. I think Shelley came up with the title, maybe between the two of us. We did ONERO, how and why it works and how we created it. That's what we're going to talk about today. Now, one of the most difficult things about these talks is not being entirely certain the background of the people I'm speaking to. And I'm glad that Grace popped up before, piped up before, and because it's possible that she's one of the people that I actually put the next slide in for. I knew that most of your crew, most of the Osteo Boston crew would be very familiar with what ONERO is, but some people maybe not. And what's really important is that we all know that we're talking about the same thing, so we're all on the same page. Because sometimes people come to me and they say, I've got osteo, and that doesn't tell me anything, because osteo is just the Latin word for bone, and we've all got bones. So nobody has osteo. They have either osteoporosis or they have osteoarthritis. And so that's what we should talk about. I would say that mostly when people say they've got osteo, they probably mean I've got osteoporosis. But what is it? So right here, you can see an illustration of that. Can you see my cursor on the screen?
Yes.
You can? Great.
We can.
Okay, so on the left, you can see what we would consider to be a normal but aged bone. And on the right, this is an aged bone with osteoporosis. And you can clearly see the difference between them. I know that this one on the left is somewhat elderly, because it does have a more convex shape than a younger bone, and also these bits of bone sticking off the top, that's actually osteoarthritis. So that's an overgrowth at the joint. But in the middle of the bone, you can see what osteoporosis is. This is a thinning of these trabeculae struts and some complete resorption of struts, and overall just a reduction in bone mass. And when that happens, the bone becomes much more susceptible to fracture. And actually, where you can see my cursor, these sort of increased densities here, these are almost certainly little compression fractures. And certainly where you can see the side of the vertebrae here has caved in, that's almost certainly a result of a compression fracture. And in some places, if we zoomed in, we might even be able to see little calluses where the bone has tried to fix itself. But if you do get these big resorption cavities here, losing these struts really weakens the bone. And so the NIH consensus statement from way back in 2000, it hasn't really changed very much, is a fracture definition. I know we talk about T-scores, but actually it's a definition about fracture, because when push comes to shove, we don't actually care how much bone we have. Your T-score is irrelevant unless you do actually have a fracture. So that's what the definition is. It's a skeletal disorder characterized by compromised bone strength, which predisposes you to an increased risk of fracture. So that basically means mostly we've lost bone mass, makes the bone weaker, and makes us more at risk of fracture. Now, when we talk about these, osteoporotic fractures are typically what we refer to as minimal trauma fractures. That means fractures that happen that would not ordinarily occur. So for somebody with normal strength bone, if they fell over onto their hands, they usually wouldn't break. But that's one of the most common osteoporotic fractures, or signs of it, is breaking your wrist. I won't dwell on this because I do think most of you probably know most of this, but just down the bottom you can see a vertebrae. So this is some of those bones in your spine, and you can see one of them here is a wedge shape. Quite often those osteoporotic fractures happen at the front of the bone in the spine and end up causing these wedge shaped. And if you put enough of them together, as this poor love has had, you can see them in the MRI if you're familiar with what MRIs are. When they're all together, you end up with this sort of curvature in the spine, which we refer to as kyphosis. The reason why I've put the image of the late Pope John Paul is because to remind us all that even though osteoporosis is more common in women, men are not immune. So that brings us to the issue that we're talking about today, which is how did ONERO come about, and why is exercise a thing for osteoporosis? How do we know that it should be effective therapy? We know that mechanical loading or physical loading of bone is important, because sort of if you look at it in the reverse sense, if you take it away, we lose bone. So a classic example in the Apollo mission in 1969, they tracked the astronauts and saw them losing enormous amounts of calcium. Where was that coming from? It was coming from their bones. It was removing the gravitational loading from the skeleton, and the skeleton is inherently a very efficient tissue, and if you don't need it, it gets rid of it. And that's exactly what happens. Same with spinal cord injury. If you unload the lower extremity, for example, you'll lose bone there. In the case of this gentleman here, you can see that he has that sort of sunken appearance of his mouth, which shows that he has lost teeth. If you look at the jaw bones over here, you can see the teeth are embedded in this jutting out piece of bone in the lower jaw here, and the same is the case in the upper jaw. If you lose teeth, and so you lose the force of the upper tooth on the lower tooth, then the bone around where that lower tooth was will resorb because there's no force on it. That's another example. And if you look at babies' jaws, they don't have that what we call the alveolar process because there's no force against the teeth there. And as they grow teeth and they start chewing, then that alveolar process develops. And it also changes the direction of that ramus there, which is that piece of bone sticking up. And then here you can see if somebody's lost their teeth, then that alveolar process resorbs. This all comes from a theory of bone loading and adaptation that was proposed back in the 1800s. Not actually by Julius Wolff, but he's the one who tried to describe it mathematically. And so the theory of bone adaptation is basically ascribed to Wolff because he was the one that spoke most about it. Now, if you look in the other direction, if you overload bone, we can see very clearly that bone will overgrow. So in this case, you can see Nadal here. You can see I've got an example of him hitting the ball. You can see the huge forces go on his dominant arm. Now, if you were to compare the bone mass between your dominant and your non-dominant arm, you would find there's about 5% more bone in your upper arm of your dominant limb. But in tennis players who really overload that limb, there's about a 25% difference. So that overload from belting tennis balls is responsible for overloading the bone and making it grow more, bigger and stronger. So it's a really an elegant model, if you like, of how exercise loading can improve bone mass. In the middle here, we've got an example from an animal model. This is a poor old beagle that had a cast put on its leg for 20 weeks, 20 weeks, or maybe it was 40 weeks. It was a long time, 40 weeks. Then they, of course, they had to walk on the other limb. So in the cast limb, you can see how moth-eaten it looks, lots of resorption here, lots of extra holes in the middle of the cortex here. It looks like a very moth-eaten thing and very much more likely to fracture when the cast came off. Whereas the side of the limb that was overloaded when the other one was in a cast, you can see lots of new bone laid down on the inside here, even a little bit on the outside. You might not be able to see that. And very thick and healthy looking cortex. So another really nice example. I've just put this image of a gymnast here because we know that gymnasts put enormous forces on their bones when they land from these tumbling runs. They can put between 12 and 20 body weights on their skeletons, and they have bones like iron. So, however, if you look at the influence of a generic exercise program on a postmenopausal woman who already has low bone mass or osteoporosis, the influence of a generic exercise program has been quite unremarkable. So what you're looking at here is what's called a meta-analysis. Some of you may be familiar with that. All of these names here are the names of investigators who have all done individual studies. They all looked at exercise programs, and a meta-analysis is a method of putting all of their data together and coming up with an average value of the effect of whatever intervention it is. And in this case, you can see the average effect was nothing. Now, this is not to say that it was bad and it was bad for bone, but it looks like there is no real effect of exercise on bone. This is very, very frustrating. This was a meta-analysis that was published in 2012, so it's getting a bit long in the tooth now. But even so, I think if you see a lot of the recent ones, not terribly much has changed. Now you can see there's an outlier here. I have put a bit of time into explaining why that is a fake outlier, but I won't go into it now because we haven't got time. So it looks, this is a little confusing. And then if you were to put exercise up against medicine that you take for osteoporosis, it also doesn't compare very well. So here you can see in the light green, this is lumbar spine bone mineral density. So those of you who have had a bone density scan, you would have got a T-score for your lumbar spine BMD, bone mineral density. And this plot is showing if you go on Prolia, which is denosumab, you can expect to have this amount of improvement at your spine, this amount at the femoral neck, which is up at your hip. If you go on alendronate, that's Fosamax, this sort of change, teriparatide, Forteo, and there's a new version of that, which name escapes me at the moment. Abaloparatide, romosozumab, this is the new one, Evenity, that's about, this is really nicely depicting a really great change in effect. Cylindronate in Australia, that is Evenity. Here it might be Timlos, I think. And here's exercise. So this sort of very sad looking effect of exercise. And if I show a plot like that to a doctor, they say, I know, right? This is why we only prescribe drugs for our osteoporosis patients. Now, this is all very confusing, though, because as an animal researcher, it's very, very obvious to me. And I showed you some examples of how exercise loading can improve bone. What is going on here? We know that it can. However, the research is showing that it can't. What is going on? Well, this is because let's assume that this is a doctor. And the doctor is thinking, well, I have a patient who looks like this. They're very, very frail. And I've got animal researchers telling me that if I want this person to gain bone, they've got to load them up. That makes me very, very nervous. The trouble is that nervousness makes us prescribe what we think is safe exercise for osteoporosis, which are exactly the kinds of exercises that would have been described in that meta-analysis. Got walking, cycling, swimming. It's a bit of seated therabands with little bands, some really light weights, again, seated, and Tai Chi. These are all low-intensity exercises, which the animal research has shown us does not stimulate bone. So here we have this situation where we have a high-risk population at an increased risk of fracture. We have doctors thinking, I cannot recommend a high-intensity exercise program because I don't want them to break. So I'll send them out to do this kind of exercise because I know that it'll be safe. Now that, as far as I'm concerned, is throwing the baby out with the bathwater. That is setting up a patient to be disappointed from an exercise intervention. Because here's an example from way back in 1985 when Clint Rubin and Lance Lanyon showed that you need to apply heavy loads or you will not gain bone mass. Here they have the microstrain is a fancy way of saying bending. When you load bone, it bends just a tiny bit. That's why it's microstrain. Strain is another word for bending. So what they showed is if you unload bone, you will lose bone. On this axis is bone area. So you'll lose bone. And we saw that in the astronauts and spinal cord injuries and so on. If you load bone roughly about the same, particularly in young adults, you'll maintain bone. If you want bone to grow, you have to apply a high strain, which is higher than what people are normally used to. So let's go back to, let's call her Muriel. She's gone to the gym and her therapist has told her, you have osteoporosis. We must be very careful with you. We're only going to give you these light weights to lift. So she sits down and she starts lifting these tiny little weights. And then she goes, okay, I'm done with my therapy. I'm going to go home via the grocery store and get my groceries. And that's what she carries home. And you can see how ridiculous that exercise is for Muriel, who is lifting way more than that just in her everyday life. That is not overload. That is not a therapeutic exercise program. So enter Liftmor. Now, Liftmor, I've put that big cannon there because that's supposed to represent bringing in the big guns. So what we did is we decided, okay, we've had enough of hearing doctors say exercise doesn't work. We think that exercise does work. We've also had enough of overly conservative therapists saying we can't overload people with osteoporosis because there's absolutely no evidence to suggest that. And we can't say that unless we actually test it. That is not science. So we were nervous, but I had 3 physiotherapists, physical therapists, as you call them here, on my team. And we recruited people who had, you can see T-scores here. If anybody needs to know what a T-score is, you feel free to ask me, but this is basically a standard deviation from normal, from healthy. And so you can see that people on average had about a -2.1 T-score in the control group and the lifting group. HIRIT stands for high intensity resistance and impact training. And at the femoral neck, same thing, quite low. And in fact, almost half of our sample had osteoporosis by T-score, which is a T-score of -2.5. Pretty average in terms of their age and height and weight, in terms of what you would expect for an osteoporotic person. You can see we had pretty good compliance in our control group. We did an active control. That was a very low intensity home program, and excellent compliance in our HIRIT group, and both of them did twice a week, 30 minutes. What did we find? Well, I can still remember the day when we found this beautiful increase in lumbar spine BMD. And this is better than anything that had been reported previously. And when you put it together with the loss across the course of the 8 months in the control group, who had only been doing the low intensity exercise, we had about a net benefit, about 4% at lumbar spine. But of the group, 84% improved in some way. So it might have been just a little bit, but some of them improved a lot. In fact, one person improved 12%. At the femoral neck, where hip fractures occur, it was very confusing to me because we only had what I would consider a maintenance effect, and I just could not figure this out for the life of me, because these women were lifting quite heavy, and it certainly would have been heavier than anything they were doing before. So this was a head scratcher to me. And even though the controls lost, so we got a nice significant effect there because we prevented that, it really was, to be honest, it was very disappointing to me. Luckily, I have in my lab some software that can reanalyze the DEXA scans and look at the 3D shape. So we're actually looking at the bone geometry of the proximal femur, or also known as the hip. The hip is actually the joint, so I tend to refer to this as the proximal femur, which is the close end of your thigh bone. And this is where the hip fractures tend to happen. Now, over here, we're looking at what's called aerial bone mineral density, which is sort of a 2-dimensional projected image, so like flat. Using this 3D hip, this is volumetric BMD, so this is 3-dimensional, and you can see there's no change in that either. But where we did see a difference between our control and our intervention group was in total cortical thickness. Now, the cortex is the shell around the outside of the bone, and this is really responsible for a lot of the strength and the resistance to bending and fracture. So over a 3.5% difference between our controls and our intervention group for the total femoral neck. But really curiously, if you went to the lateral side, just this side here, we had nearly a 30% improvement in lateral cortical thickness at the femoral neck. And that's when I started getting really excited, because, of course, that is where the fractures tend to happen. If you fall on your hip, you tend to fall on, that structure is called a great trochanter, and if you fall to the side, that's what takes the brunt of it. So the femoral neck tends to break. So, and that's where it propagates. So this was exciting, and my frown turned upside down, and I was happy after that, because I didn't worry so much about the BMD effect.
Wow.
It was a wow moment. Yep.
Yeah. Thank goodness you had the extra technology there to measure that.
That's right. And, all of my clinical trials, sadly, have been unfunded. Very, very, very difficult to get funding for exercise trials in Australia. And so we run them as PhD projects. So they have very minimal funding. So we can't afford to do other sorts of scannings like CT scan, where we could also do this. But this is a very helpful option. So then I guess we measured lots of other things, because it's really important to remember that osteoporotic fractures are not all about bone. So bone mass being very low certainly increases your risk of fracturing if you fall, but 90% of hip fractures occur because you've fallen. So it's really, really important that a therapy, any therapeutic intervention, actually addresses the falls as well. And this is the problem with medication. Medication doesn't do anything for falls. So we measured these functional outcomes, and these are risk factors for falls. So function, what you can do. So down the bottom here, you can see, and this is on the y-axis here, this is percent improvement, how much these people got better. So LES stands for leg extensor strength. And you can see that there was just over a 27% improvement of difference between controls and intervention. For back extensor strength, how much they could push their back upright, there was a 33% improvement. These are very big numbers for functional improvements. Timed up and go, this is getting up from a chair and walking around a dot on the floor about 3 meters away, in your words, but a bit more than 3 yards, and coming back and sitting down again. So that's a sort of an indication of your mobility. 5 times sit to stand, about a 10% improvement or difference between groups. All of these were statistically significant. Functional reach, leaning forward as far as you can without falling over. That's a measure of static balance. And vertical jump. This is how much power you have to get up off the ground, about 4% difference. So again, I was pretty thrilled, particularly with this one, leg extensor strength, because that is a really important risk factor for falling. If your legs are strong, you are much less likely to fall over. And I'll show you later why back extensor strength is so important too. So I'm hearing you all thinking, yes, but did you hurt anybody with this heavy lifting program? And the answer is, well, I'm coming to the safety one. First, before I do, I want to talk about posture. Now, this is one of our participants, and we measured her kyphosis. Remember I talked about the curvature at the top of the spine is called kyphosis. She is in a deadlift position, so she's leaning over and she's holding onto a bar, and she's trying to straighten her back. So when she first started, she had this fairly extreme kyphosis for somebody. She was in her 60s. By the time she got to the end of her intervention in the study, she had considerably reduced that. Now, it's not a miracle cure. It's not going to completely straighten somebody who has established kyphosis. That would be crazy. but what it is, it's improving posture. And you can see that when she was trying to straighten her back as much as possible, she could only look at the floor. By the time she'd finished this intervention, she could definitely look in front of herself, and that is extremely important for your risk of fracture, risk of falling. Also, if you look over here, our control group lost height. whereas our intervention group gained a bit of height, and obviously people aren't growing. So this is really an indication that people's posture is improving. So we measured them saying, stand at attention, stand up as straight as you can. And they actually were able to stand taller. So overall, about a 5% reduction in kyphosis. And we also scanned them from the side. Now, normally when you have a bone density test, you don't get scanned from the side. And that's fine. You don't need to be to get an idea of what your bone density is. But if you're doing research, we wanted to actually measure and see if anybody's vertebral bones, you can see all these little segments here, whether they changed in height, because if they did, it would be indicative of a crush fracture. And that's what we were nervous about. Nobody had a crush fracture. Everybody's vertebrae looked pretty much the same in terms of the shape by the end of the study. We had one person who had a mild back strain during one of the exercises in 2,600 training sessions across the whole study. And she went away, had a bit of physical therapy and came back and kept lifting. So very, very mild, and we didn't hurt anybody. We certainly didn't cause a fracture.
Great. Do you think she was doing it incorrectly?
No, look, the thing is, you know, I'm a pragmatist. You have to keep in mind that when you do exercise, particularly high intensity exercise, you are putting yourself at risk of injury. If you do it properly, your risk is very low. But every so often, you know, a muscle will just go, no, I just don't want to do that. And you'll strain it. And it does happen. It happens reasonably rarely if somebody's technique is great. But it's, you know, it is the risk of doing exercise, but as I say, very, very, very low risk.
Yes, very few people, one person.
Yeah. So I'm not going to go through all of this because it's you know, it's the evening. You guys will start going to sleep if I start reading dot points. But really the take-home message from this is just to show you, with all the evidence behind it, that having a deteriorating posture, increasing kyphosis, increases your risk of falling. So anything you can do to improve somebody's posture is a good thing. It reduces falls, ergo, it reduces fracture. Okay. So now, again, I have so much data, we could be here into the middle of next week. So instead of doing that, I'm just going to show you the publications where we've published our data, so that to prove to you that this is not Mickey Mouse research. JBMR, Journal of Bone Mineral Research, is the most prestigious bone journal in the world. And we have had all 3 of our clinical trials, the primary findings, published in that. It's been fully peer-reviewed and accepted for that really high-quality journal. The first study to be published was Steve Watson. He was my PhD student, and pick the annoying supervisor who can't help themselves but put rabbit ears behind all their students. And so this was the first publication showing the results that I just showed you. Then we also published that it didn't cause vertebral fractures. Then along came Amy Harding. And if you can see, there's a couple of rabbit ears behind Amy's head as well. And this was when she graduated. She was the one who ran the Liftmor for Men trial. And my co-investigator, Ben Weeks. And she also published in JBMR showing it worked in men as well. Interestingly enough, we used the OsteoStrong device, which used to be called Biodensity. It used to have 4 exercises all in one. I think they've pulled it apart now and created 4 devices. We showed that OsteoStrong had no effect on bone mass. And we also reported thoracic kyphosis and fracture in that group, and showed that it was safe. Incidentally, in the OsteoStrong group, we did see 5 incident fractures. So this may not be a no harm intervention if those of you are considering doing OsteoStrong. And what was this? This was reporting the 3D hip outcomes. And then along came Melanie Kissler-Fischbacher, a double-barreled name. She comes from Switzerland. And she actually did the MedXOP trial. And this was a trial where we wanted to see whether if you took medication into account, would it improve the outcomes of the ONERO exercise program? Unfortunately, we weren't able to recruit tons of women on medication because, as you all know, people just don't like them and don't want to go on them. So we didn't get really robust findings on that, but it did seem from these early findings, we only had 15 in each group, that adding medication to ONERO didn't actually make it better, but possibly adding medication showed an improvement in BMD at the femoral neck. And if you remember, you don't get a massive increase in BMD at the femoral neck with ONERO alone. So I'm not sure, but presumably that does mean adding medication to ONERO possibly can improve BMD at the hip. And we used as our control group Buff Bones, which is a modified Pilates exercise, and we showed that Buff Bones did not increase bone mass. In fact, in our control group, they lost 1.5. So Pilates is not high enough intensity to increase bone mass. And finally, we looked at the hip bone strength indices as well. So that's the whole summary of all of the clinical trials. I'm not going to harp on about that because I want you to all stay awake. Now, some other important information. And so, it is important that others, if they don't replicate your findings, they at least do some research or publish some data that seems to align with yours. And in this case, Hoffman published a meta-analysis showing that supervised exercise seems to make a difference to osteoporotic fracture, but unsupervised does not. And I think that really is a marker of intensity. So most of the high-intensity exercise programs would be supervised because people are nervous, and obviously I think it's very wise. And so they confirmed what we had found. If you look at this meta-analysis, these guys put together these very low-intensity exercise programs. There is no effect of exercise, possibly a maintenance effect, but predominantly supervised. These trials here, and this doesn't even include ours, but they refer to these as supervised, and you can see there is this favoring the exercise group effect in fracture prevention. Now, fracture is a really hard outcome to measure in exercise trials because if you don't have a very, very large sample, you can't measure fracture because they are actually relatively infrequent events. So you need a massive sample. So this is just interesting to show that with a fracture outcome, it looks like these supervised trials are effective. And they summarize that by saying that supervision plays a significant role. And interestingly enough, also, the World Falls Guidelines came out in 2022, and they also concluded that if you wanted to prevent falls, supervised exercise programs are also the most effective. So I guess what we want to know, though, is if this program can actually work, be effective, and be safe in the real world. Because as you'll probably know, in the clinical trial world, there is a lot of care with the subject selection, and so we don't always recruit people who are at the highest risk because we're nervous. We don't include people with other comorbidities like cancer and Parkinson's and all of those sorts of things. We want to know if the ONERO program does. So that's what the Bone Clinic is. And because Shelley had asked me a couple of questions at the start of the study, you are aware that that's what the Bone Clinic is. It's a translational research facility set up specifically to safely translate the high-rate exercise into a clinical practice and apply it for people with low bone mass. And so you can see my receptionist there, Donna, Pinky, and Katie, who's my exercise physiologist, has been with us since we opened in 2015. And he's one of my dietitians because we also include a dietitian consult. You need to have the building blocks if you want to build bone. It's not an intervention. We don't give people any supplements or anything. We just assess their diet and and we adjust it where we think that they're not getting the right building blocks. But because this talk is about exercise, I won't talk anymore about that. So what do we actually do at the clinic? Well, firstly, we assess them. Now, ignore GPMP, that's an Australian thing. This is something because people in Australia can actually get some reimbursement for that assessment, and we do a diet assessment. Now, that assessment is just like we did in the Liftmor study. So pretty comprehensive. We do all our own bone scanning. We do all that functional testing, and we do some quality of life surveys and all sorts of stuff. And then we offer them twice weekly training in ONERO. And as I said, we've called the program ONERO, and it stands for overload. I also give educational seminars 4 or 5 times a year. And so it's teaching people other things about osteoporosis and how we can optimize other aspects of their life and lifestyle that can prevent fracture. And then we do a 12-month follow-up. But remember, this is real life. These are real patients and clients, and we don't, they're not obliged to come back if they don't want to or if they don't live near us. So we send them a reminder when their 12-month appointment is due, but if they don't come in, that's entirely up to them. It's also entirely up to them how much or how little they train. So most people want to train twice a week, but as you would know, life gets in the way sometimes, and many people have carer duties and grandchildren, and then they take holidays and people get sick. So compliance is often not as good as in a clinical trial. It's what people can do, what they can afford, and what they can manage. So what I'm going to show you is a sample of people. This was analysed a while ago now. Since I analysed this, COVID intervened. That really messed up my data because we were shut for 4 months and it took people quite a long time to come back to the clinic because they were very nervous. So we were shut for 4 months, but we probably lost about a year of data, and I need to sift through that. I now have almost 9 years worth of data, which I'm very excited, but I need to really take a good, careful look at that and be pulling on a biostatistician to help me with that. So the sample that we're looking at here are people who have at least 12 months exposure to ONERO. So that's 415 people, of whom 6% are men. The average age is sort of mid to early 60s, but there is a large age range. Our very youngest person who is currently training with us, I think, is 23, and our oldest is probably 92. We used to actually have an older demographic, I think, but the word is out, and people now are understanding that the best way to manage osteoporosis is to prevent it. So we've got lots of people now coming in and lifting to prevent the first fracture, which I think is extremely sensible. Pretty typical sort of height and weight here, but a lot of variation. You know yourselves that the classic osteoporotic woman is normally very slight build, but that is not always the case. And T-scores, about -2 on average, but probably with the lumbar spine. This is probably artificially inflated. I would say if you took out all the arthritis that sometimes obscures the bone in our DEXA scans, you would probably see that actually the average bone mass at the spine is probably lower than this. In terms of the average compliance in this group, about 60%. Now, 100% compliance means they've come twice a week for 48 weeks of the year. I give them 4 weeks off if they want. But some people actually come more than that. As I say, they can come 3 times a week if they want. They just need to have 1 day rest in between because they need to recover.
May I ask a question?
Sure.
This is Shelley. I just wondered, with those scores, those T-scores seem like what we would consider in the United States, osteoporosis starts at -2.5.
Mm-hmm.
So you're taking people with osteopenia? Is that what I'm?
Oh, absolutely. Anybody who wants to come to the clinic can come.
Okay.
And
Sure.
particularly as you're probably aware that the vast majority of people who sustain an osteoporotic fracture do so when they're osteopenic. this is because there are more people who are osteopenic than osteoporotic. It's purely a statistical fact, but most people fracture with osteopenia. Osteoporotic people are more at risk because they've got weaker bones. There's just more people with osteopenia. So it's really, to my mind, it is extremely important that we get the message out that people with osteopenia should be lifting.
Thank you.
Also, sadly, we have somebody at the clinic who has a T-score of -6. So, yeah, we do have some very, very frail people. Don't let these scores obscure that. Tons of people with -3, lots with -4. Yeah. So now, also wanted to flag that 107 of these 415 were actually on medication at baseline. There were only 29 of those people still on medication at baseline, at follow-up at the 12 months. Now, I tell people that they should listen to their doctor and they should stay on their meds. If they've been prescribed meds, they should stay on them, particularly in light of the dramatic loss that you see if you come off Prolia. So these people are told, please stay on your meds, but oftentimes they're coming to us because they want to come off them. And they're very disobedient and they do what they please. And so as you can see, they haven't listened in this group and they've come off. So here are our results. So what this is looking at percent improvement. So that's what the y-axis is here, percent improvement. It's not percent change, because if I did that, all these negatives would go below the bar and it would make for a very small plot. So I've just put improvement because all of these negatives are actually good things. They're good outcomes. So for example, you can see percent fat went down to went down 4.2%. So that's a good thing. So all of these changes are good. So we're calling them percent improvement, even though there are some negative values here. So first of all, we see weight, and you see it's about a 1% change in weight. And a lot of people would think, well, I don't want to gain weight. But if we go over, and I've already told you that there's about a 4.2% loss in percent fat. But if you look over here, you'll see lean mass, which essentially represents muscle. And you can see there's a 2.3% gain in muscle. So any of this weight, this is good weight. We want muscle. We definitely want more muscle and less fat. We don't actually care about fat. You know, it doesn't matter too much, but we do care about muscle. So this is a good outcome. Looking at height, we've got a 0.001% improvement in height, which of course is really just a maintenance effect in height. And that is a very good thing when you know that as we get older, we're basically starting to shrink. So this is helping to at least maintain height. The bone outcomes, lumbar spine, BMD, femoral neck, BMD, and whole body BMD, they're all going in the same direction. And this magic number of 3 for lumbar spine is very, very consistent, even in our folks at the bone clinic. So I think what we're saying here, and the answer is, does it work? And in the real world, the answer is yes, it does. Now, in green over here, we're looking at those functional outcomes that I showed you before in Liftmor Study. So these are the ones that are risk factors for falling and fracture. So kyphosis, we've got a reduction in kyphosis, the curvature of the spine. We have an improvement in functional reach. Remember, that's the one where you lean forward and that's the static balance. Tandem walk is where you walk along a single line with your heel to your toe for 6 meters, and we time you. And you can see that a reduction in time means you're doing it more quickly. So, and that is a marker of dynamic balance. Balance when you're moving. Definitely a risk factor for falling. Timed up and go, also an improvement because there's a reduction in time. And 5 times sit to stand, also an improvement because there's a reduction how long it took to do 5 sit to stands. And then here's back extensor strength, very much the same sort of improvement as we saw in the Liftmor trial. People just have much, much stronger back strength. So these are all the mean improvements. And remember, these are people who have gone off, many of them have gone off bone medications. And if given that in Brisbane, Prolia has a 76% market share, that means some of these people have gone off Prolia, and we know that you have a rapid loss, particularly in spine and hip BMD when you come off Prolia, and we seem to have still managed to have an outcome which is in the positive, even though we've got a bunch of people in this sample who went off bone meds.
Incredible.
So people often ask me, 3% doesn't seem very much. Well, it is quite a bit, particularly if you do it every year. But I think what is really impressive is this is what we call a waterfall plot. So every one of those 415 people I've plotted along this scale here. So each of these lines, which you can hardly see, they're very, very pale green and red. These are all an individual in this sample. You can see one person gained over 25% at the spine in the course of a year. Remember, percent change, this is a percentage of what the person started with. So that was almost certainly somebody who was very low to start with, so a percentage of their own spine BMD. And so lots of people are gaining quite a lot of bone at the spine, the average about 3%, because we do have a small number who are not gaining bone. But this is about 82% increased. That is a pretty good response rate.
Yeah.
And then at the femoral neck, 78%. Probably the most was about 20%. These are big numbers, really big numbers.
Especially you had so many, I'm sure you have people who go away on a vacation and they're gone, and there's so many other variables. So
that's right. Yeah. And we saw that in compliance, a 60% compliance. So that's, 2/3 of the time that they could have been lifting.
Yeah.
All right. Is it safe? This is the question. So in this sample, 415 people, there's nearly 45,000 training sessions. Had a total of 28 injuries. So this is tiny. These are mainly soft tissue injuries. And, if you go to your local gym, you're probably having 28 injuries a week. So, and in a healthier, your sort of young adult population. So we're pretty proud of that safety record. There was a 51% decrease in falls in that 12 months versus the previous 12 months. And that also is pretty impressive, because in most falls intervention trials, normally the reduction in falls is about 30%. So this is exceeding that. Fractures, almost 80% reduction in fractures. Now, I say that with a slight squint, because our numbers are very small. So we'll keep tracking these, and I'm hoping that the number will stay as high. But say comparing maybe 20 fractures to 2, you can see those numbers are small, but it can be quite a large difference. So this is great. Now, this is a person who had 7 vertebral fractures when she started lifting. She's, so this is somebody obviously with a very frail spine, and she's managed to improve her kyphosis enormously and no more fractures. Now, I just wanted to show you this email, because this is just a very typical email that we get from our clients. This is from August last year. Hi, Belinda and the Bone Clinic team. I wanted to share with you what happened at my annual visit to the doctor this morning. The results of my bone density test and blood tests had returned, and Dr. D said all the results were good. The bisphosphonates had worked well. I didn't interrupt her when she went through and explained all the positive results, no losses, some improvement. It was at the end when I said I'd chosen not to use the drugs. Her eyes went wide and eyebrows arched in puzzlement. Then I told her that I had chosen to go to the bone clinic and try diet and supervised exercise routine instead. She claimed it was a remarkable result and was quite excited. So thank you so much, all the team, for such a good result. Can't wait to see what happens next year review. I mean, again, I am not anti-medication, and I don't tell people to go off meds, and I don't tell people not to go on meds. I am pro-exercise. And so if people are for whatever reason, hesitant to go on meds, they can at least try this. They encourage them to do what their doctor says, go on meds if the doctor says so. There is nothing to stop you doing both. All right, so I'm just going to very, very quick summary of slides to sort of put in context some of what I've been saying and a little bit else. So fractures. We know what contributes to fractures: low BMD and poor bone geometry, poor bone shape, and falls. We know what contributes to falls: muscle weakness, poor balance, impaired mobility, functional limitations, kyphosis, pain, arthritis, and so on. All of these other things, visual impairments, dizziness, taking lots of different drugs, having a previous fall, all of those things contribute directly to falls, and some of them contribute directly to fractures as well as to falls. Now, if we improve those things, those falls risk factors, improve muscle strength and balance and mobility, if we reduce kyphosis and pain and arthritis and diabetes, we can reduce fall risk and obviously reduce fractures. Bone drugs work on bone. So they're going to hopefully, not always, but hopefully improve BMD, and there's some evidence to say that they also improve bone geometry. But exercise does all of these things. It's the thing that improves all of these falls risk factors, and it improves BMD and bone geometry. And when it improves muscle strength, it indirectly improves BMD and bone geometry. So it has this very powerful effect, and an often unrecognized effect on fractures by way of preventing falls and also improving bone mass. It's a really powerful message that I'm trying to tell people about, because most people think it is all about the drugs. And when we look at this plot that I showed you before, remember I showed you where all of the bone drugs seem to really outperform exercise. And we look at actual fracture reduction from the drugs. In fact, exercise performs really well. Meta-analyses show us that exercise has a 51% reduction on fracture, probably because of its additional effect on falls. So it's really, really important for us to get the message out there. Doctors are not taught about exercise in medical school. They are taught about drugs. So this is not the fault of doctors that they don't know this. I think it's my role to tell as many people as possible that there is this very strong evidence, so that we can provide that evidence and reinforce the doctor's message. It's not all about drugs. It absolutely should be about exercise. Now, there are messages about exercise that I feel are quite destructive. Some people might think this is controversial. I don't think it's controversial. I know I won't make any friends by saying this. However, I think it's really important that we get the message out that there are only certain exercises that improve bone, and I've shown you the evidence of that. The IOF is the International Osteoporosis Foundation, and they are responsible. They're like a repository of really important information about osteoporosis, and I encourage you to go there. They've got some fantastic information about nutrition and drugs and all sorts of stuff. I am not saying there's anything wrong with the IOF, except their exercise information. They have an app right now called Build Better Bones, and on that app, they are telling you that these kinds of exercises are good for bone. Now, I don't know if you can see, just I'm zooming through because we don't have all night, but these are extremely low intensity exercises. There is no evidence that those exercises are going to increase your bone mass. There's actually even no evidence that they're going to stop you from falling. So the reason why these have been created, I am certain, is because of this worry about people hurting themselves if they are frail, and I understand that. So I just think it's important that we make it very, very clear. Are we protecting people and wanting them to sit in cotton wool on the couch? Or are we actually trying to give them exercise therapy that will help them? It seems plausible that any old low-intensity exercise will help, but it won't. And actually, people are going to lose bone mass if that's the exercise they do, because it's not enough. It's almost like doing nothing. Exercise for osteoporosis is highly targeted therapy. You would not give people aspirin for osteoporosis, you give them bone drugs. In the same way, you don't give people low-intensity exercise for osteoporosis, you give them ONERO. So now that brings us to this point. How do we do this? And I'm really aware of the fact that you guys are the Boston crowd. And right now we're trying to get you somebody who can deliver some ONERO in your backyard. How I do it in Australia, you can see on this map. This is the ONERO licensing map, and that's the web address for it. It comes up like this, but you scroll into your location. So in Australia, there's tons. The rest of the world, not so many. There's the ONERO Academy is how I train my licensees, very comprehensive training. So people don't have to come to Australia to do it. It's about 6 hours worth of training. And it's pretty straightforward. If you do zoom in, so I've zoomed into the US here, and you can see there's still not that many here. However, I should say there are more licensees that are on the map. It's just they haven't finished their training yet, so I haven't put them on the map. There will be hopefully somebody in Delaware, in Buffalo. There's 2 in San Diego, 1 in Fort Collins, and 1 possibly in Ashland in Oregon. These are people who have all either bought a license and are in the process of training and getting set up, or they're very close to signing up. So I know that's not enough. I know there are people who will be very frustrated that there isn't anybody in their backyard, but the best way to do it is to contact your local PT or exercise physiologist. I only sell licenses to those clinically trained therapists, because this is not a program for just your average personal trainer who doesn't have a strong clinical background, because we know that it's a risky program, and people with osteoporosis often have many other comorbidities that need to be managed. So of course this is the hot spot that we're trying to fill the gap. We're looking for a PT here, and hopefully there'll be some interested people to coming to help you out. Down here, this is an awfully long drive for you. You've got 2 on Long Island at the moment and 1 in New Jersey. Actually, there is likely to be another in New Jersey as well very soon. So that's the task at hand at the moment.